These are my disclosures. I have funding from various federal agencies, and I'm also a scientific advisor for the Longevity Foundation. I'm going to go through the NLST results. I think many of you in the audience have probably seen these results, been to talks in which they were discussed. So I will briefly review them, but I'd like then to move on to a discussion of what the screening harms are and where I think our opportunities are, specifically as we migrate into the notion of screening implementation. So the backdrop for the NLST began in the 70s. As most of you know, there were a number of trials that were conducted that looked at various combinations of chest X-ray and sputum cytology as a method for detecting lung cancer early and for reducing lung cancer mortality. And what they found in those trials was an increase in the number of early-stage lung cancers with no significant decrease in late-stage lung cancers and no mortality benefit. So we need to flash forward now to the 1990s. And in the 1990s, a number of observational or single-arm trials with lung cancer screening were conducted in Asia, in Europe, and in the United States. Probably the two most conspicuous of those trials, or the two best known of those trials, were the LCAP, conducted by my colleague Dr. Henschke in New York, and the Mayo CT trial. But I would have to say unequivocally that what put CT screening on the map in the United States was Claudia and the group who ran the LCAP. And I think she deserves a huge thank you for having actually made this such an important aspect of what we are now thinking about. These trials did show that there was an increase in early-stage lung cancer and that there was an improved survival. And it was against the backdrop of that that we undertook the National Lung Screening Trial. As you know, it was a randomized trial, and it combined two different groups. One was a contract run through the National Cancer Institute, and one was a grant sponsored by Akron, which was that portion with which I was affiliated. We randomized 54,454 individuals in a 1-to-1 ratio to receive either low-dose helical CT scans or chest X-ray, looking for a 20% mortality difference at a power of 90%. We followed these subjects for a median of 6.5 years and up to a maximum of 7.4 years. We were fortunate in that we had some very aggressive site investigators and study coordinators, such that we have collected outcomes on well over 95% in both of the arms. So in the NLST, the interpretation criteria were pretty much binary in that you had either a negative screen or you had a positive screen. And a positive screen was defined as any study in which there was a nodule of at least 4 millimeter diameter or some other suspicious abnormality, central mediastinal mass, lobar collapse, pleural effusion, something like that. And in the setting of positive screens, there was always some recommendation for follow-up that was typically based on the initial nodule size and consistency. We had two categories of negative screens. The first was your vanilla-style negative screen in which there were either no or only minor significant abnormalities. But the second negative screen was negative in the context of finding suspicious for lung cancer. However, other significant pathology was identified, and this was usually something like an aortic aneurysm or the finding of a lesion within another solid organ. And in that case also, some form of recommendation for appropriate follow-up was also made. So this table is kind of a busy table. I'll walk you through it a little bit. Along the top row shows both arms at each of the individual time points for screening and the total number of individuals who were screened at those time points. The second line shows the percentage of those screens that were positive. And you'll notice that we had about a 27% positivity rate at the prevalent screen, meaning the baseline screen, and at the first incident screen, which dropped down to a little under 17% by the T2 screen. This was largely because an abnormality that had been seen and was stable over a period of time could be called negative at the election of the radiologist. The important point here is that, in fact, using the NLST definitions, we had a screen positivity rate overall of about 24%, and that it was threefold higher than in the chest X-ray arm. Not only that, but we also had a threefold higher rate of these significant other findings, which I won't be discussing today. The other interesting point on this slide is that the bottom row represents, within the patients with a positive screen, the numbers of lung cancers that were detected following that positive screen. And I think your attention should likely be drawn to the fact that in only 3.6% of all of the positive screens was there, in fact, an associated lung cancer diagnosis. So that means that our positive predictive value was less than 4%. And it wasn't much better in the chest X-ray arm. So what did we do with all of those positive screens? Well, the most common procedure that was done, aside from an office visit or maybe an office call, was an imaging examination. And not surprisingly, the most common imaging examination was, in fact, a chest CT. Of interventional procedures, we looked at percutaneous biopsy, bronchoscopy, and surgical procedures, including mediastinoscopy, thoracoscopic surgery, or thoracotomy. And across these, surgical procedures were the most commonly performed procedure, interestingly. And thoracotomy was the most common surgical procedure. Now, over the course of the trial, the numbers of thoracoscopic procedures did increase, but never surpassed the thoracotomy rate. If we look at the kinds of lung cancers that were detected by the screening result and to some degree also the time period, we can divide those cancers into screen-related cancers that were observed between the T0, T1, or T2 screens, lung cancers that occurred in ostensibly negative screens, and also lung cancers that occurred absent screening, 90% of the time, which was after our screening interval during the period of observation. So a couple of things to note. About 61% of all of the CT lung cancers were in fact screen detected. In contrast, about 56% of all chest X-ray screens occurred in the no screen time period. The other interesting point is that the cancers that were diagnosed in face of a negative screen, so this would ostensibly be interval cancers, was higher in the chest X-ray arm. We're going to look at the same data in a bar graph, and I'm going to walk you through this a little bit. Along the x-axis are early stage or 1A lung cancers, a category that we'll call intermediate stage ranging from 1B to 2B, and then finally advanced stage lung cancers, stage 3 or 4. Each of these bars represent either the CT or chest X-ray arm and the distribution of stage across the entire trial. The gray represents those cancers that were screen detected. The light color represents those cancers that were in negative screens, and then the blue area represents the lung cancers that occurred absent screening. So, major points on this are that, number one, we did realize a more than doubling in the the detection of early lung cancers, or stage 1A lung cancers, which we were pleased but not surprised to see. Secondly, of those early stage lung cancers, the vast majority of them in the CT arm were screen detected, whereas in the chest X-ray arm, early cancers occurred fairly equally between screening and no screening time periods. The second point is that the cancers that were diagnosed in face of a negative screen were most commonly advanced stage lung cancers. And this was true in both the CT and the chest X-ray arm. We're not surprised by that. We would expect that a cancer that develops in face of a negative screen would be biologically aggressive. So we would be comfortable in appreciating that those would likely be advanced stage lung cancers. And then finally, with respect to advanced stages, there was in fact a legitimate, true decrease in the absolute numbers of advanced stage lung cancers, which tells us that we did, with screening, see a stage migration to earlier stage lung cancer. When we looked at the complication rates in these people as they were undergoing their various procedures, we divided complications into 3 categories, and those were major, intermediate, and minor. I've only shown the major and intermediate complications on this slide, but you can see that most of the major complications were centered on either respiratory or cardiac arrest or myocardial infarction, and then any one of a number of post-surgical complications. Intermediate complications were lesser degrees of respiratory distress or cardiac ischemia, and then kind of a potpourri of different kinds of related complications. So when we look at these complications, I've divided the 2 arms into those who had lung cancer and those who did not have lung cancer. And you can see that among those individuals who did have a lung cancer in face of a positive screen, major complications occurred in just under 12% of individuals. However, death occurring within 60 days of an invasive procedure was actually pretty low in the CT lung cancer arm, and in fact is a little less than the national average as it has been published. What's even more important is the fact that among those individuals with positive screens in whom there was no lung cancer, the complication rates were very low, such that our overall complication rate was low. The complications in patients in whom cancer was never diagnosed were really minimal. So we introduced very little harm with the trial. This is a slide of the causes of death of the NLST participants, and you can see that the top players, not surprisingly, are lung cancer, other cancer, a cardiovascular death, or a respiratory death. And when we look at the differences between the CT and chest X-ray lung cancer death rates, normalizing per 100,000 person years, that difference, the lower rate of mortality in the CT arm, is what in fact translated into a 20% mortality benefit relative to chest X-ray and an absolute reduction in death of 4 per 1,000. What we were not powered to see, but what was in fact observed, was also a 6.7% decrease in all-cause mortality. And what this tells us is a couple of things. First, it tells us that the trial did not, the screening intervention itself did not provoke some other event that would result in death. But as importantly, it also means that those individuals who were saved from their lung cancer, they did not succumb to a lung cancer death in the CT arm, didn't then the next day die of a stroke or a myocardial infarction. And that is critically important, and I'm not sure that this has ever been shown before, certainly in the context of a screening trial. So to summarize what we found more lung cancers with CT than chest X-ray. We observed a true stage shift and a decrease in the absolute numbers of advanced stage lung cancers. We saw a 20% relative mortality reduction and an absolute reduction in lung cancer deaths with few complications. What also gives me great pleasure is the fact that as the national PI of the NLST, there were 23 Akron sites. And of those, 21 of the 23 sites were run with the PI being a radiologist. And I would have to tell you, quite honestly, that we were most of the time really flying by the seat of our pants. But the reality is that this is one of the single most important contributions to lung cancer and reducing lung cancer mortality that we will see for a while. And it was a bunch of radiologists that did it. So I want to thank all of you who participated in that. Okay, so what's next? Bill will be talking about the cost-effectiveness analysis that is underway with the NLST data. I wanted to spend a little time addressing screening harms. I think probably the most discussed of the screening-related harms would be radiation, and I'll discuss that briefly. The fact that we had such high positivity rates in the CT arm and very high false positivity rates. And then finally, this whole notion of overdiagnosis, in which we are picking up a lung cancer which is so biologically indolent that it would not result in the death of the individual, or we pick it up and in fact they die of a competing illness. Depending on how you look at the numbers from the NLST and what you use in the denominator, the estimate can range anywhere from 12 to 18% or so. Based on the autopsy literature, it would be about 15%, so I think we came out pretty consistently with what the historical epidemiologic literature would suggest. So I want to talk a little bit about radiation dose. Someone far more knowledgeable in this area than I actually spoke here on Saturday, and that was my colleague Mike McNitt-Gray from UCLA, who gave a lecture on radiation dose with respect to computed tomography in the COPD session. When we talk about radiation dose, we frequently refer to whole body effective dose. And if you do that, then you can say that a low-dose helical CT is about 1.5 millisieverts, a chest X-ray is really very small, and mammography is about half that of a low-dose helical CT scan. And we like to correlate that with the natural sources of radiation that we see at sea level, which are estimated to be about 3 millisievert per year. And it gets higher as you go above sea level. So that in, for example, Denver would be about 4.5. Well, in point of fact, what we're interested in looking at or trying to understand is radiation-related carcinogenesis. And to understand that, we actually have to look at organ-specific doses. So if we do that, a low-dose helical CT would deliver about 4 milligray to both the lung and the female breast. We can contrast that to screening mammography, which also delivers about 4 milligray to the female breast. But the big difference between the two is that the area contained within the volume of that low-dose helical CT also delivers a milligray to the marrow, to the stomach, to the liver, et cetera. Whereas in the context of mammography, that collimation is so tight that in fact there is negligible radiation effect to the other organs. So if we translate these into population risks of cancer, we know that about 1 in 3 individuals will develop a cancer in their lifetime. And if we add a chest CT onto that, then we can roughly estimate that about 1 in 1 to 10,000 additional individuals would develop an additional lung cancer. So if you have 1,000 people and 1 in 3 of them develop lung cancer, that would be 333 people. And if they get chest CT scans, then 334 would get that. Well, this is even lower in the context of screening CT because we reduce the radiation dose. And I think we're just beginning to figure out how much we can reduce radiation dose based on newer iterative reconstructions, compressive sensing, et cetera, that is being done in lieu of filtered back projection with computed tomography. So I think the story on that remains to be determined. The other problem is that these are based on most of these are based on the survival data from Hiroshima. And we don't really know what happens with periodic low-dose CT and whether those effects are truly cumulative. We can't really study this in human beings well, but you actually can get some estimate of radiation-related carcinogenesis in a Petri dish. As it turns out, what happens with radiation is a breakage in the DNA strand. So you get these double-stranded breaks in the DNA, which immediately activate kinases that phosphorylate histones. And one of those histones, which when phosphorylated is gamma H2AX, is a marker of double-stranded breaks in the DNA. So if we expose Petri dishes, all other variables held constant, to radiation, we will see an increase in these phosphorylated histone complexes that begin anywhere from 30 minutes and peak at about 90 minutes post-radiation. If there are excessive numbers of these complexes, that usually indicates lethality, and the cell will die. But these can actually be replicated in daughter cells so that you can develop clones that have these double-strand DNA breaks, these mutations, and you can follow those mutations and look at the differences between cumulative effects over time from small doses delivered at intervals versus larger doses. And I think we'll probably try to be using this to model, to some degree, the kinds of carcinogenic effects that we might expect from low-dose helical CT. Well, how else can we improve what we're doing now? And I think clearly there is room for improvement on what was defined as screen positivity. As I mentioned to you at the outset, the NLST had a binary decision point. The screen was positive or negative. Our neighbors across the Atlantic in the Nelson trial that's being conducted in the Netherlands use a two-step process that goes something like this. This is, I'm showing the prevalent screen only. The incidence screen algorithm is very comparable. At prevalent screen, a negative screen is any finding of a nodule that is less than 5 millimeters. And in that instance, the individual is simply encouraged to come back for their follow-up screen a year later. Those nodules that are over 10 millimeters are considered abnormal and typically undergo some form of definitive workup, which frequently was an invasive procedure like bronchoscopy. The gray zone of nodules between 5 and 10 millimeters were considered indeterminate, and those patients automatically came back at 3 months for a follow-up examination. Based on growth characteristics, they were then assigned to either negative or positive scores. So if you look at this and the performance characteristics that they derived from this algorithm, their positive predictive value is 10 times higher than ours is on prevalent screen and improves even more on the incidence screens. So let's break this down a little bit. What are the implications of using such a two-step process? Well, first of all, we're clearly going to improve our performance characteristics. The numbers are going to look better. However, relative to what occurred among NLST participants, there's probably no significant difference in medical resource utilization. So is this a cosmetic fix to make the screening exam look better? And I would posit that that is in fact not the case, that there is in fact a benefit from considering an algorithmic approach like that. And that is that it makes the implications of the screening result much more realistic, much more valid. And that is important to both the participant who has the positive screen and to the primary care physician who's now going to be responsible for following up on that, hopefully in conjunction with us. And then finally, it tells us that screening is really a process. It isn't a one-stop thing. It is a process that is delivered over a period of time. With respect to overdiagnosis, I was talking to my colleague Bill last night when my friends were telling him about bad stories about me. And my comment is that I think I had a better understanding of what overdiagnosis was before this trial than I do now. And I'm showing you anecdotal experience here, but this is the reason why. And that is that this is a female patient who had a sub-centimeter small ground glass nodule, and over a period of about 3.5 years, we followed that nodule, and I think most of us would see that it got larger over that period of time, but it was still sub-centimeter. And we recommended that she come back in, and she was having nothing to do with it and didn't really come back until she had an obviously invasive adenocarcinoma. I think one of the issues that we're going to have to address is how we manage these patients, because in fact, these are not linear growth models for lung cancers. So we can't say come back in a year or come back in 2 years necessarily. At some point, they may in fact sustain their next genetic hit and their growth curve becomes exponential. And we don't know when that happens. And I think that's one of the problems with this whole notion of overdiagnosis. The surgeons love it when I say that. Here's another problem that I think we have, and that is the conundrum of management. This is an example of a patient who had a percutaneous biopsy-proven adenocarcinoma and had a satellite nodule in that same lobe. So this was clinically a T3 lesion. This would ordinarily go for a lobectomy, hopefully a thoracoscopic lobectomy. However, what do you do with all the other lesions that are in the lung? And I think this is increasingly going to be observed in patients who are at high risk for lung cancers, and because of the sensitivity of the tests that we're using. And we will need to figure out better ways than cutting out lung parenchyma to manage them. And it may be some combination of ablative therapy or stereotactic radiosurgery. We don't exactly know yet, but this is definitely now on the radar. So what can we do as radiologists to improve the performance of the test? And I think one of the things that we can do is better risk profiling. So the two biggest risks for lung cancer that we used, which were appropriate, was age and smoking history. However, among smokers, only about 15 to 20% of individuals get lung cancer, and how do you pick those folks out? And it turns out that among individuals who are smokers, those with COPD are disproportionately affected by lung cancer. And some would suggest that it's anywhere from 60 to 80% of individuals. We usually look at this based on spirometry, or I think as we are now migrating towards a molecular area, there are a number of individuals working with either SNPs or circulating cytokines or proteins that hopefully will be able to validate using some of the biospecimens that were collected during the NLST. But what can we do? And that's not the right slide. So let me tell you a little bit about the SNPs, and that is if you think about the alpha-1 antitrypsin as an example, and this is a generalization, but in those individuals who have alpha-1 antitrypsin disease, those folks are at risk for developing emphysema and COPD. If they smoke, that likelihood is infinitely greater. So they have a genetic predisposition. This is not a mutation that has occurred over time. They were born with this. Well, we also may, in fact, determine that through SNP analysis, we will find that some individuals have a particular phenotype that puts them at risk for lung cancer. And this is one of the tables of some work that's been done by a guy by the name of Robert Young in Auckland, New Zealand, who has developed a panel that, based on some epithelial cells from the nose that he gathers, they run this test, and in fact, in preliminary testing, this substantially stratifies individuals for risk for lung cancer and COPD. Well, what can we do? We can use the image data. We know that spirometry is a risk factor for lung cancer, but we also know that emphysema is an independent risk factor for lung cancer, with or without spirometric evidence of airflow obstruction. And a similar thing might be said with respect to airway remodeling and the changes that we frequently associate with smoking-related bronchitis or airway disease. If we, in fact, use those, I think we can better approximate in individuals those who are likely to have lung cancer. And this may have great value with respect to diagnostic stratification in individuals who have indeterminate nodules. What I've shown you on the right side of the slide, I just love this picture, is a visualization that is generated by a commercially available software, Vita software. And what this does is it separates the lung into its lobes based on color. Then it also identifies the distributions of emphysema, and so that we can see that this is clearly an upper lobe distribution of emphysema. It's a very heterogeneous pattern of disease. But these little clusters here are, in fact, their size is based on how many contiguous clusters or voxels of low attenuation are next to one another. So you get some idea of what the texture of this emphysema is and its distribution within the upper lobe. So, for example, there's a fair amount of paraseptal emphysema along here. These patterns we are only now trying to make sense of to, in fact, inform the subphenotypes of COPD that are at highest risk. And I think this is another one of the major reasons why we need to be thinking about migrating towards computerized analysis of our exams. As I mentioned, the same thing can be done for the airways. There are ways of segmenting out the tracheobronchial tree. You can line the tracheobronchial tree up linearly so that you can subject the airways to a variety of measurements that are associated with airway remodeling from smoking damage, like airway wall thickness, changes in the lumen, et cetera. So I think this actually forms a very important part of the analysis of individuals who come in for screening. The third area in which I think there is now, there has been consistently a lot of interest, I think there's now even more or a resurgence of interest, and that is trying to get at something beyond just the volume of the nodule, but to try to develop mathematical descriptors of the features of these nodules that would better predict malignancy. So in the case of these two nodules here, we can get a volumetric assessment, which, by the way, is very challenging with part solid nodules and in ground glass nodules. But we can also look for specific features using frequency distribution curves and looking at lung attenuation parameters such that we might be able to develop signatures of abnormalities that would suggest this is likely to be a lung cancer or this is likely to be an invasive lung cancer. What are the threats to us? Well, I think the biggest threats to the community of researchers and individuals who are interested or who have smoking-related diseases is that there is grossly insufficient money devoted to lung cancer. I pulled this from a couple of different sources. This is from the Cancer Statistics from the CA Clinician Journal from this year, and this really looks across 5 different lung cancers at the incidence and mortality of these cancers. This is a download from the NIH and shows over the past 5 years what the funding levels have been. And it's extraordinary to me that even now we remain less well-funded, having the highest mortality cancer in the United States by far. We are still the least well-funded for research in lung cancer, and this really has to change. Okay, to round this up, I think when we consider implementation, and I hope that the cost-effectiveness analysis will in fact help to inform CMS and the Veterans Administration Hospital that we should be implementing screening in some fashion, we're going to need to look at the stakeholders. And when I divide the stakeholders up, I think of those that provide the service, and of those that provide the service, the radiologists clearly have an obvious part in this process. Our challenges will be standardization of the acquisition parameters, of our interpretation standards, and of our follow-up algorithms. The other major challenge will be disruption of workflow, because this is disruptive of workflow to be reading a bunch of low-dose helical CT scans. And I think the Europeans have it right. I have not seen this done to any degree in the United States, and I'd be interested in if any of you do this. But the European countries that are doing screening, and particularly the Netherlands, do use commercial CAD systems that help them to identify these nodules and to do volumetric analysis on them. And if we are to do that, it's clearly not going to be you and me that are sitting in front of the CAD computer. It will have to be trained staff. It will have to be perhaps technologists or perhaps other trained individuals who can analyze skillfully those images and then pass that data off to us. I think we will also have to look at the primary care providers. Their workflow will also be disrupted. First of all, they're a fairly conservative bunch, and they will have to be convinced that CT implementation or screening implementation is important. If they've made that decision, then they're going to have to incorporate educational processes into the way that they see patients. And they will have to reconcile how much time they want to spend with respect to lung cancer screening advocacy relative to other known health preventive measures that they currently advocate. And then they're going to have to follow these patients up. So I think the primary care people are a major component of the implementation process, and how we do this with respect to primary care will have a huge influence on how successful we are. Finally, we have to get to the people who are at risk. And in some instances, it is a matter of education. In some instances, it's just a matter of exposure. Has the primary care physician even suggested that you might want to quit smoking? The other problem, however, will be that lung cancer is unique among cancers in that it is presumed to be due to the bad habits of the individual. And there's a certain fatalism associated with lung cancer. And we've got to get past that, because clearly most of the people getting lung cancer now, or at least slightly over half, are former smokers. They got the message. They're still at risk for lung cancer. And then finally, I think probably the single most important problem that we have is that certainly now lung cancer screening is only really paid for by a few providers, by a few insurers. And it certainly isn't, obviously, with Medicare at this point. The problem that we will have is that because, at least right now, the costs for screening are greater than for some other screening and other health prevention measures, that this will be a utility for those who are economically able to pay for screening, and we will once again disadvantage disproportionately those who are socioeconomically disadvantaged, and that would be a huge mistake. So, having said that, what are people doing for screening clinics? And I certainly don't pretend to have an answer for it, but I do feel fairly strongly about some of these issues. First, it should be transdisciplinary. Everybody in the party should be getting together, all of the subspecialists. It's not just radiology, it is the surgeons, it is the pulmonologists, it is the pathologists, it is the primary care people. And we need to approach it not from, here's radiology's program. We need to approach it from, this is a program to reduce lung cancer mortality, and we're all going to share in the risk, and we're all going to share in whatever profit there may or may not be. The other thing I think we need to be doing is looking more closely at risk stratification, as I've already mentioned, as well as diagnostic stratification in the setting of an indeterminate nodule, by looking at questionnaires, performing spirometry in these patients, doing their imaging and analyzing their imaging for the risk signatures that we can see on the image data, and then by collecting the specimens that will ultimately allow us to get closer from a biological perspective on risk. These have to be embedded within very aggressive smoking cessation campaigns, and I personally think that that's really one of the areas in which CT screening can play a larger role. But we have to get a little bit more serious about smoking cessation, which we don't do a good job of in the United States. And then finally, as I mentioned, we have to coordinate this care across the continuum of patients from the moment of screening to the moment that we cure their cancer.